This group was also very important because they were a status quo disruption. Without this group and without their first step into advocacy work in the United States, we wouldn't be where we are now. It's just that simple. And so while they were controversial and highly progressive at their time, they were still very valuable for where we are now. This brings us into our next group, the Compassion in Dying Federation, or just Compassion in Dying is how they are referred to usually. This group also talks about giving people the option to hasten death, but they talk more about, just in their mission statement off the cuff, they provide more information, consultation, and emotional support to people, so it is a more hands-on group already. And so we're going to talk about this group differently. We're going to talk about their conceptualizations of death with dignity, not on a timeline scale, but based on the variables of patient-doctor relationship, medical technologies and protocols, and legal and policy factors separately. So this group's biggest push for patient and doctor relationships is to communicate honestly and openly with your patient. And so they believe that patients' needs have to be heard, and they also believe that a doctor should never abandon their patient, that doctor should be the shepherd of that patient's illness and their dying process all the way past death, and that they also these doctors should be facilitating patients' needs along the way, not just communicating what their treatment options are, but also how do we achieve those options. And so this will bring us into the legislative piece in a second, but they also, along with this, believe that doctors should communicate that hastening death is an option. They don't just talk, though, about physician-assisted dying. There were other options that they talked about to help hasten death, such as like increased pain medication, terminal sedation, other things that were legal. However, legally speaking, this organization did aid in writing and legalizing the first Death with Dignity Act in the U.S. in Oregon. It was passed in 94, I think, 93 or 94, and then it made it into action in 97. But the founders of this group actually helped draft the act, and they drafted and defined the criteria for people being able to qualify for this Death with Dignity Act because they had a wealth of clinical experience behind them. The founders were doctors, hospice care workers, hospice nurses, and they used all of their clinical experience to define which people were terminally ill, mentally competent, able to make their own decisions, not making this decision based on outside pressures, and had truly exhausted all other options. And so this was very important for creating this act. And you can see here on the chart, this circled area is the era that Compassion in Dying operated directly within, and then the shorter boxes are people who died using the Death with Dignity Act, and the taller lines are people who received prescriptions for the Death with Dignity Act in Oregon. So you can see that there was definite usage with this group during this time, and that they did push for that to be an option for patients. Also, they do not support physician-assisted dying outside of the medical system, and also it's important to note here, forgot to mention it a second ago, that this group was moving away from the terminology of suicide and euthanasia because of the connotations of it, and also because of the way that it affected patients and the integrity of patients. And so they start defining that practice as physician-aided dying or physician-assisted dying from here on out. Okay. As far as medical technologies and protocols, Compassion in Dying really heavily advocated for hospice and palliative care to be used to its absolute full potential. And so this means that conversations needed to happen earlier for patients whose curative treatments were no longer working, about how to have support treatments, how to have different levels of comfort in their care, how to move out of the hospital and to the house or to another comfortable place that's familiar to them to receive their treatment. And then they also noted that comfort care here is key to preventing suffering at the end of life, and that if that comfort care is used correctly, people might actually want to live longer, or they do live longer and their symptoms don't drag out their suffering. And so this little graphic over here, we haven't actually discussed yet how palliative care and hospice care works. Palliative care is also noted as comfort care, and then hospice care is when a person is very close to death and goes to a comfortable place to receive their nutrition, pain medication, hydration, whatever their care plan is at that point. It's outside of the hospital, it's surrounded by family and friends, and they have a lot more control over relieving their suffering symptoms, and they tackle all of the different areas of a person's life, so daily life, having some sort of routine, their spiritual involvement, their community around them. Their mind is their sense of self, their identity, their deterioration. There is a lot of dementia and deterioration affiliated with some of these diseases, including AIDS, and then meeting their goals at the end of life. And also, of course, having their family around them. So this is how palliative care works. In a nutshell, there's a lot more to it than that in hospice. This group's main technology that they advocated for was using palliative care, but they also did advise how to pursue physician-assisted dying for patients who did qualify for it in areas where it was legal. Okay, so this block quote is important. It's from Barbara Coombs-Lee, who is the founder of this organization, and this was taken from an interview with her towards the end of the organization's existence. And so pulling from this quote, dying patients deserve the best we can offer in symptom management, adaptive technology, psychosocial support, and spiritual comfort. So this is where they're tackling patients' needs. They also deserve a sense of control over the degree and duration of deterioration and suffering they endure. The choice of assisted dying gives patients that sense of control. Many never exercise the choice, but they can all experience a heightened sense of autonomy and peace of mind from knowing that it is theirs to make. So this organization is definitely advocating for choice and control over individualized control and autonomy over a patient's own personalized dying process or illness process, and they do advocate that choice to have assisted dying as an option to them does actually help the patient's peace of mind and comfort at the end of life, even if they don't utilize that choice. They say that peace of mind, endurance, patient autonomy, these are worthy goals for a healing profession, and that compassionate dying does try to integrate those choices whenever possible. Okay, compassionate choices is the last group we're going to talk about. They have a lot of similar viewpoints and stances as compassion in dying, so we're going to talk about how they're different instead of how they're similar, so everything from here on out is going to be the nuances that they moved forward with. But you can see in their mission statement that they're including a lot of other things already other than just hastened death, such as improving care, expanding options, empowering everyone to chart their own end-of-life journey rather than being an unwilling passenger on their own end-of-life journey, and that they envision a society that affirms life and accepts the inevitability of death. So again, they're trying to brand death as not being something that's unnatural, or rather death is natural. Okay, so we're going to talk about them quickly in a nutshell. So as far as patient and doctor relationship goes, they again are communicating full range of treatments. Talk to your patient, tell them everything that's available to them, including palliative care options, not just curative options. There's a fun quote from this era in the organization too that says that sometimes when you're doing curative options, aggressive curative options too for patients who are dying, when I say curative, it's probably like chemotherapy or other things that are meant to end the disease and save that person or give them their normal life back. In these cases, that's not going to happen. The disease has already overpowered the balance of being able to cure or not cure here. But yeah, they want you, sorry, go back to that quote. The curative options for this area, they do say in a quote, I think it was Barbara Coombs-Lee who said it, that we're not actually prolonging life for these patients, we're just prolonging their dying process. So they're already dying, and instead of giving them extra life, we're just giving them more time with this excruciating or emotionally taxing dying process. So there's a definite separation of those two things, and it's important for doctors to identify, are we in a dying process now, or are we in a curative stage still? And it's important to this organization that doctors identify that and have that honest communication with patients that maybe the curative treatments are not the best option anymore. Maybe palliation is where we should be. They also state that alleviation of suffering is a human duty. We're going to talk more about this under the